Hello to everyone. Today I'm going to talk about a randomized trial of Hyperimmune Globulin to prevent congenital cytomegalovirus. But first, I'm a med student at the Universidad Católica de Santiago de Guayaquil, and here I'm on Facebook, Twitter, YouTube, and Instagram account so you can follow me and watch the other videos I have uploaded. First, we need to know what is congenital cytomegalovirus. Congenital cytomegalovirus occurs when an infected mother passes cytomegalovirus to the fetus through the placenta. The mother illness may not have symptoms, so she may be unaware that she has cytomegalovirus. Hyperimmune globulin. Hyperimmune globulin is similar to intravenous immunoglobulin, except that it is prepared from the plasma of donors with high titers of antibody against a specific organism or antigen. Generalized infection may occur in the infant and can cause complications such as low birth weight, microcephaly, seizures, petechial rash, similar to the blueberry muffin, rash of congenital rubella syndrome, and moderate hepatosplenomegaly with jaundice.
So now let's talk about the major clinical syndromes that CMV can cause. So the three main ones are infectious mononucleosis, congenital disease, and disease in immunocompromised hosts. Now, Epstein-Barr virus, or EBV, is the most common cause of infectious mononucleosis, or mono. So we're going to talk about mono when we talk about EBV. But just remember that CMV causes almost 10% of mono cases. So let's move on to congenital infection, and that's actually potentially much more serious. So congenital infection happens when a pregnant woman gets a primary CMV infection or sometimes reactivation. And I'm sure you've heard of Down syndrome. You might have heard of spina bifida or fetal alcohol syndrome, but what you probably don't know is that congenital CMV is more common than any of those. And that's probably because pregnant women are so often exposed to young kids who can spread it to them, and also because CMV can cross the placenta. So 1 in 100 babies in the US are born with CMV, and of those, 1 in 5 is going to have symptoms or sequelae. And the disease can range in severity from mild to fatal, but possible signs of congenital CMV infection at birth include premature birth with low birth weight, hepatosplenomegaly, respiratory distress, microcephaly and seizures, and a petechial or purpuric rash. So that's all stuff you might see at birth. And then long-term complications can include intellectual disability, vision and hearing problems, seizure disorders, and problems with weakness and coordination. So finally, let's talk about CMV in immunocompromised hosts. And the issue is that in transplant recipients receiving immunosuppressive drugs or in advanced HIV infection, CMV can reactivate and actually cause serious illness. In fact, CMV is probably the most important post-transplant viral infection. And when you do a transplant, you actually always assess the CMV status of the donor and the recipient, because that's going to determine the risk of CMV disease and also the monitoring plan for it. So what kind of disease does it cause? Well, CMV can cause fever, pneumonitis, hepatitis, colitis, lots of itises, as you can tell, as well as transplant rejection, and it can actually precipitate graft versus host disease. Now, in advanced HIV disease, CMV can also reactivate. And when we say advanced, usually it's when the CD4 count gets below 50. And in that case, CMV is most likely to cause retinitis, which can lead to blindness. And this is what the eye might look like if you looked inside it relative to a normal eye. So it can cause retinitis or colitis or esophagitis. And so these are all the main complications of CMV that you need to know.
Application in medicine. Some agents against with hyperimmune globulins are available include hepatitis B, rabies, tetanus toxin, varicella zoster, and the administration of hyperimmune globulins provides passive immunity to the patient against an agent. Even though in this study the administration of hyperimmune globulin apparently had no effect on the virus-specific T-cell responses, there was no significant difference between the two groups or within each group between the women who transmitted the virus and those who did not. With respect to levels of virus-specific antibodies, T-cell-mediated immune response, or viral DNA in the blood, the clinical outcome of congenital infections at birth was similar in the two groups.
In this video, we're going to talk about cytomegalovirus, which we call CMV. And if we wanted to be really precise, we should say human cytomegalovirus because there are other non-human cytomegaloviruses. But we're just going to say CMV. So CMV is HHV5, and it's a beta herpes virus. And it receives a lot less press than the other herpes viruses, and that's probably because the vast majority of cases are asymptomatic. However, it can do a number of things. It can cause a mono-like syndrome. It can cause serious infections in immunocompromised people, especially AIDS patients and transplant recipients. And it's also the most important congenitally acquired infection in the US. And we'll talk about all these things later. But although it receives less press, CMV is totally ubiquitous. Up to 90% of 80-year-olds have CMV antibodies. You can acquire it any time, especially early childhood and adolescence. So why is it so common? Well, that's because it's transmissible in so many different ways. It can be transmitted directly from person to person or via fomites in the environment. Sexual transmission occurs. The one thing it can't do is spread through the air like VZV because CMV does not get airborne. But it's shed from saliva, urine, cervicovaginal secretions, breast milk, even semen. It can be acquired prenatally, perinatally, postnatally. Breastfeeding is a mode of transmission, and then it can also be transmitted in blood transfusions and even more importantly in organ donation. So really almost every way that you could imagine. And when kids were studied in a daycare center, a third were secreting CMV in their urine, saliva, or both. So all in all, as you can imagine, because CMV is shed so commonly and from so many different places, it's really hard to prevent transmission. So let's quickly go over the pathogenesis of CMV. So it's secreted in almost every imaginable way. And then how does it infect a new host? Well, usually by getting in through the upper GI tract, the genitourinary tract, or the respiratory tract. So that's actually more common than the blood transfusion, transplant, breastfeeding kind of stuff that we talked about. And from there, it infects lymphocytes that traffic around the body, and it hitches a ride on those cells and spreads to multiple tissues. And whether it causes a symptomatic or asymptomatic infection, cell-mediated immunity is critical in controlling the virus. And then, like a good herpes virus, CMV establishes latency. And the cells that it establishes latency in are myeloid progenitors in the bone marrow. And these can differentiate into circulating monocytes that will also be carrying the virus. So this is a virus that's great at immune evasion. It literally hides out within the immune system. And like other herpes viruses, since it's latent, it can reactivate and cause either symptomatic disease or asymptomatic infection, in which case it can still be spread to other people.
Pros and cons. Pros. Only about 1 out of 10 infants congenitally infected with cytomegalovirus have these symptoms: inflammation of the retina, jaundice, large spleen and liver, low birth weight, mineral deposit in the brain, rash at birth or petechio, seizures, and small head size or microcephaly, known as microcephaly. The cons: the number of obstetrical adverse events was higher in the hyperimmune globulin group than in the placebo group, 13% versus 2%. Treatment with hyperimmune globulin didn't significantly modify the course of primary cytomegalovirus infection during pregnancy.
The reason we thought that CMV hyperimmune globulin might prevent congenital infection of CMV are a couple. First, there's a long history of hyperimmune globulins potentially stopping infections during pregnancy. The second is there were prior data done in Europe that suggested that there might be some benefit of administration of hyperimmune globulin to prevent congenital CMV. Yes, the trial was stopped early at enrollment of 399 patients because the Data Safety Monitoring Board felt that the likelihood of showing benefit was so low that there was not any potential benefit of continuing the trial at that point. What we found, unfortunately, is that CMV hyperimmune globulin did not decrease the rates of congenital infection or fetal death among women with primary CMV infection during pregnancy. We also found that it did not decrease the risk of symptomatic congenital infection among those that were infected. And there was an increase in some of the side effects that we were looking for among women who actually received hyperimmune globulin. So unfortunately, we found that it did not benefit women or their fetuses or infants, and potentially had increased side effects.
Issue applied in Ecuador. In Ecuador, there was intrauterine transmission in 37% of the cases. Congenital infection was diagnosed antenatally in 30% of infected fetuses and postnatally in 60% of fetuses. 8% of fetuses with a negative viral load at amniocentesis had a positive viral load at birth. Of the group that received hyperimmune IG, 30% have congenital infection and 34% of the placebo group, and there were no significant difference in the viral load in the amniotic fluid of the infected fetuses and the viral load in blood or urine of the infected newborns. In conclusion, hyperimmune IG did not significantly modify the maternal viral load in the blood of the or the time it takes for it to disappear, not the viral load in the placenta. There were no significant difference in blood viral load between women who transmitted the virus and those who did not. These findings are not able to support that hyperimmune Ig will reduce the placenta maternal viral load by a direct neutralizing effect, as has been proposed by previous studies. Administration of hyperimmune Ig also does not disappear to have an effect on the viral specific T response.
Hi, Asantha. My name is Allison August, and I'm one of the physicians at Moderna working in the infectious disease division, helping to develop all of the new vaccines.
Hi, yeah, thanks. Thanks for inviting me to do this. My daughter's Amari. She was born in 2007. And she was diagnosed with congenital cytomegalovirus. She's not able to walk or talk, but she is a feisty little gal. She gets her point across. She makes sure people know what she needs or wants.
Can you share with us a little bit about what your day-to-day life caring for Amari is like?
It's care all day, and she's not able to feed herself or change herself or bathe herself. We kind of have our routine and our groove, and we get into it. Don't feel sorry for us. We got this. If you see us on the street, say hi, smile. We're nice people. There was this one time, this little boy, he comes up and his question was, what is wrong with her brain? And that was so profound to me, right? Because normally kids might say, why can't she walk? What's wrong with her legs? Or why can't she talk, right? But he knew there was something going on in her brain that was causing everything else. And I just thought that was so amazing. And we had a really long conversation about that.
That boy clearly was remarkable, and I agree. The question was really amazing. But also, you're amazing because you've clearly created an environment where people are comfortable to approach you about such questions. Well, thank you, Asantha. Thank you for your bravery and your courage, and stories like yours are what keep us going.
My biggest hope for her, that she just gets to continue to interact with people, laugh with people. That would make me really happy to see her live that life for a long time.